All right, so just to start out, I'm going to be assessing my patient's mental status. I'm going to be assessing their affect, their thoughts and perceptions, language, speech clarity. I'm going to be looking at their height and build, how they are dressed, their hygiene, as well as their general affect. Can't remember if I already said that. Going to be looking at their orientation. So, can I have your full name?
Jake,
And then can I have your date? Or what's the current date today?
November 1st, 2024.
And where are you at today, Jake?
I'm at my house
And why are you here?
for an exam.
Perfect. And so patient is alert and oriented times 4. I'm going to go on to my integumentary exam. I'm going to be first inspecting, looking at hair distribution, which is normal for a male. I'm going to be looking at for any open areas, lesions, bulges, masses, looking for any edema, any irregular vascularities, if they have tattoos, piercings, um, and just general color of the skin, which is normal for his race. And then I will begin to palpate. So I'm looking at for temperature, moisture, and texture. My patient's skin is warm, dry, and smooth. I'm going to test turgor, which is non-tinting. I'm also going to be looking at the hands and palpating the hands and the nails for any deformities. Nail shape is normal. There's like contour to them. No signs of deformities or clubbing. I will also go ahead and check capillary reflex. Perfect. It's less than 3 seconds. Going to be going into my head and face exam. So I'm inspecting for symmetry of the facial features, which are very symmetric. I'm looking for any edema or any lesions or masses. I will begin palpating. I'm palpating the facial bones as well as the facial and maxillary sinuses. Any tenderness with that? Nope. And then I'm going to palpate the temple mandibular joint. Can you open and close? Perfect. Move it side to side. Perfect. And there's been no clicking. Did you have any tenderness?
Nope.
Okay. And so I will go on um, to assess cranial nerve number 5 or my trigeminal. I've already assessed motor, and so now I'll assess sensation. I'll have my patient close their eyes and tell me what sensation is being felt on either the ophthalmic, the maxillary, or mandibular portions of their face.
Sharp forehead, sharp chin, soft left cheek.
Okay, and I would do that bilaterally across all like areas of the face. We'll say that cranial nerve 5 is intact. I will also observe cranial nerve 7 or the facial. And so I will do that by testing cranial nerve 7's motor first. I'll have you smile for me, frown, batter your teeth, and then puff your cheeks out, whistle, raise your eyebrows. And I'm looking for any symmetry of the facial features. And he was symmetric with all of his facial expressions. For cranial nerve 7 sensory, I would be testing taste. I would be applying sweet and sour, bitter and salty taste on the anterior 2/3 of the tongue, and having my patient tell me what they are tasting. And cranial 7 is intact. I'll go on to assess the eyes. I'm going to be assessing the eyebrows and the eyelashes. Good hair distribution, very symmetrical. I'm looking at the sclera, making sure it's nice and white. I'm looking for any signs of icterus, which I see none. I'm looking at the iris as well as the pupils. They're both symmetrical bilaterally. I'm going to look at the conjunctiva. It's very pink bilaterally. And then I will go on to my ophthalmoscopic exam. I'm going to be testing that red reflex. I'm going eye to eye. I see that red reflex, and so I'm going to go on to my fundoscopic exam. The fundoscopic space is clear yellow. There are no cotton woolies or any other debris that I see. The vascularity is as it should be, no microaneurysms. And then I'm looking at that optic disc. I'm making sure that it's nice and defined, very sharp, no papilla edema, and also with that macula. And then on my way out, I will be observing the lens, making sure that the lens is clear, which it is. There are no nicks or pulsations. And then I will be testing cranial nerve number 2, 3, 4, and 6. We'll go by testing cranial nerve 2 first, which is the optic. I would be testing visual acuity with the Snellen chart, color discrimination with the Jaeger card, and then I would be doing the cover test, which would be testing peripheral fields of vision. Have my patient go ahead and, or convergence field. Anyway, cover the eye. And then tell me how many fingers I'm holding up.
2, 3, 1.
Perfect. And so I'm going to have my patient keep his eye covered because I'm going to test for convergence here. Go ahead and uncover for me. All right. And there was no eye movement, and so that is intact. I would also be testing for extraocular movements and nystagmus. So I'm going to have you follow the tip of my pen here. And also for accommodation, I'm going to be testing for pupillary response. So I'm going to shine a light in your eyes. Perfect. I'm going to do that obliquely. And I'm going to also be looking to make sure that the pupils are responding consensually, which they are. This is also testing cranial nerves 3, 4, and 6, which is my ocular motor, trochlear, and abducens. And then going on from the eye, I would go to the ears. I'm making sure that my ears are symmetrically placed on the face, which they are. Looking at the outer ear, looking for any signs of redness or irritation, any masses, which I see none, so I'll go ahead and palpate. I'm palpating that auricle, the tragus, and the helix, as well as the mastoid, and no masses are present. I'll look into the ear canal, pulling the ear up and back for an adult, and then I'm looking at that ear canal, making sure that it is free of lesions or redness or inflammation. There should be no drainage. I'm looking at the amount of cerumen, which is typically scant. I'll look at the tympanic membrane, which should be intact and pearly gray and not non-bulging. I'm also looking for my landmarks, which would be the cone of light. In the left ear, it will be at 7, and the right, it will be at 5. Also for the long handle, the malleus, the annulus, and the umbo. I will also be testing cranial nerve number 8, or my acoustic nerve. I would do so by doing the whisper, the Weber, and the Rin. I'll start by doing the whisper test. And so I'm going to occlude one ear and have my patient repeat back to me. Baseball.
Baseball.
Perfect. I'm going to do the Weber. So I'm have my tuning fork here. Going to strike it, place it on the head. What ear do you hear that better in?
Both.
Okay, perfect. And that is testing for lateralization. I'm going to do my Rin, so tuning fork. I'm going to strike it and place it on the temporomandibular joint. And then I'll have my patient tell me when they can no longer hear the noise or hear anything. Then I'll be timing it, placing it in front of the ear. Have my patient again tell me when they are no longer able to hear that. What we are looking for is a 2-to-1 ratio. So he should be able to hear air conduction 2 times more often than bone conduction. After the ears, I will go on to my nose assessment. So I'm just looking for symmetry of the nose. Again, any lesions, bulges, masses, any tenderness while I palpate.
Nope.
Perfect. So I'm also looking to make sure that the septum is midline, which it is. Looking at the turbinates with my otoscope, I'm shining a light up there. Turbinates are grade 1. The nasal mucosa is moist and pink. There's no discharge, no exudate, no polyps, as well as no edema present. I am then going to test my cranial nerve number 1, which is the olfactory. I'll have my patient test for patency by occluding one there and then sniffing, doing that bilaterally. And then I would have 3 scent jars. I would have my patient close their eyes, occlude one there, then test the scent. They would tell me what they smell, and then cranial nerve 1 is intact. And so next we're going to go on to the mouth. We're gonna first start out by inspecting the lips. His lip border is nicely defined. It is moist pink and free of lesions. So I'll have my patient go ahead and open their mouth. I'm assessing their teeth and then gums. My patient has good dentition and no signs of gum recession. I'm looking at the oral walls. The oral mucosa is pink and moist, free of lesions. I'm gonna turn on my light. Can you say ah? Okay, that uvula or cranial nerve 9 glossopharyngeal is intact. I looked at the tonsils, they are a grade 2, and that soft palate is mobile. I'm looking at the tongue. The top of the tongue is pink and moist. Can you raise your tongue to the roof of your mouth? Perfect. That is also pink and moist, free of lesions. Looking at the bottom of the mouth here, and I'm looking at the Wharton ducts and then the parotid glands, which are visible and free of lesions. I'll have you stick your tongue out at me, which is midline. That is cranial nerve 12, hypoglossal. And then I would elicit cranial nerve 10 or the vagus nerve by using a tongue blade to elicit the gag reflex. To palpate the oral cavities, you would use bimanual palpation. So to do the bottom oral floor, you would have your patient stick their tongue up to the roof of their mouth, place your hands inside, and then place your other hand at the submental process and then press in together. This is useful when trying to determine if the ducts are clogged or if there's any masses. And then going forward, we're going to go on to my neck exam. So I'm making sure that the neck is symmetrical. I'm looking at the size. There are no masses, no pulsations. I'm looking to make sure that that trachea is midline, which it is. I'll go ahead and begin palpating. And I'll do my temporal artery there, grade 2. Then do the carotid, grade 2. Other carotid, grade 2. I'm going to go ahead and palpate my lymph nodes at this point in time. I'm going to do the pre-auricular, the post-auricular, the occipital, anterior cervical, posterior cervical, supraclavicular, and then down below the collarbone, that would be infraclavicular. Lymph nodes, they should be about the size of the pea. I was on part of submandibular and submental. The lymph nodes should be no larger than a pea, and someone his age, they should be smooth and pliable. I was unable to palpate any. Going forward from there, I'm going to go ahead and feel for the thyroid here. So I'm going to just feel for my landmarks, feel the cricoid process there, and then go down just a little bit. And then the thyroid is right there. I'm assessing size, shape, symmetry, texture, and any nodules. So my thyroid is approximately about 4 centimeters. And he's just swallowed, so I was able to feel it move slightly. It is smooth. It's about the shape of a butterfly and free of nodules, and it is pliable. So going from there, I would then begin, I'm going to assess my cranial nerve number 11, which is the spinal accessory nerve. So I'm going to have my patient go ahead and flex their head forward, extend your head back, move your head to shoulder. All right, and then shake your head no. Shrug your shoulders. Okay. Spinal nerve or cranial nerve 11 is intact, and strength is 5 out of 5. From there, I'm going to go on to inspect my thorax and chest. So what I'm looking for is I'm going to be examining the rate and rhythm of breathing, making sure that the breathing is effortless. There's no accessory muscle usage or substernal retractions, which there are none. My patient's breathing is at a regular rate and rhythm and free from and effortless, essentially. From there, I'm going to be looking for any heaves or lifts or any pulsations above my landmarks for the heart, which is my aortic, pulmonic, tricuspid, and mitral. and then I will begin percussing. So I'm percussing in a bilateral ladder pattern, and what I'm assessing is for the quality and pitch over the heart, or it should be dull, and then over the lungs, it's going to be more resonant. And then after that, I will begin to auscultate. And then I'll have my patient take a deep breath every single time my stethoscope touches their chest, but for this, don't. I'm also going to listen to the heart while I'm here. So again, that aortic area in the second intercostal space, the pulmonic in the left second intercostal space, tricuspid between the 3rd and 5th intercostal spaces. Those are at the sternal border. And then we're going to do the mitral, which is at the midclavicular line, and then at the 5th intercostal space. I would be auscultating the heart with both the diaphragm and bell. And then I'm gonna just take a minute to point out my landmarks here. So we got the clavicle, got the superior and inferior clavicle suprasternal notch, manubrium, angle of Lewis, takes you down to the sternum to your xiphoid process. This is the general bony thorax, which is the thoracic cage. The intercostal margins, the intercostal margins is just that angle where the ribs splay out. Your sternal line, your midclavicular line, your anterior axillary, and then the medial axillary, posterior axillary, and then that should be it for my landmarks on the anterior portion, and then I'll go to my posterior. All right, so for my posterior chest exam, I'm going to first start by inspecting. I'm going to be looking at the C7 to the T1, which is that bony prominence there on the neck. I'm going to be looking at the vertebra as well as the musculature surrounding that. I see that there are no masses or bulges or tenderness when I palpate. I'll again just go ahead and palpate for any masses on the back, and then I will do CVA tenderness. So I'm going to take my hand, place it in a fist right at that intervertebral costal margin line. Any tenderness when I did that?
No.
Okay, good. And so then I would do diaphragmatic excursion. So I'm going to have my patient take a very deep breath in and hold it. And then from that infrascapular line right there, I'm going to percuss down until I hear that area of dullness. You can let your breath out. I'm going to mark that with a pen, and then I'll have you take a deep breath out and hold it. And then again, I'm going to go right underneath that scapula, going to percuss down until I hear that area of dullness, which is right there. I would mark that with my pen. You can breathe. And that area should be no more than 3 to 5 centimeters, which it is not. Then I'm going to be doing testing for thoracic expansion. So I'm going to find the 10th rib, and then I'm going to put my thumbs close to the spine and have my patient take a deep breath in and out. Good. And then I would take a moment just to point out my landmarks again. So this is my spinal line, the scapular line, the interscapular line, infrascapular line, and then of course the spine. I'm also going to be percussing on the posterior, but I've already done that on the anterior, so I'm going to skip right to my specialized testing. We're going to do the whispered pectorality, and I'm going to have my patient whisper 1, 2, 3 every single time that my stethoscope touches their back. Okay. And so I would do that throughout all the lung fields, and I would also auscultate for the lung sounds on the posterior portion as well. But for the sake of this, we're just going to do the one side. But whispered pectoraliloquy, when they do whisper, it should be faint and distant. We're going to go on to bronchophony. I'm going to have my patient state 99 every single time that my stethoscope touches their back.
99, 99, 99, 99.
And again, I would do that through all the lung fields, and 99 should be muffled and distant. And then we're going to go on to egophony. So I'm going to have my patient say E every single time my stethoscope touches their back.
E, 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 E.
Okay, and I would again do that throughout the entire lung field, but if the E were to sound like A, that would be an abnormal result. And then from there, I'm going to go ahead and have my patient sit back. And we already listened to the heart sounds going into my cardiac exam. And so he had a regular rate and rhythm. I was able to hear the S1 and S2 without any extra heart sounds. No splitting, no clicks, no murmurs, no friction rubs, no gallops of any kind. And so what I'll have my patient do at this time is I'll have him go lay down on the exam table. All right, and so I'm just gonna again begin an inspection process of the chest. What I'm looking for is if there's any pulsations in the carotid, any pulsations, heaves, or lifts over the main points of the heart. I see none, and so I'm gonna go and measure jugular vein pressure. And so I'm gonna have my patient turn their head off to the side until I see that slight pulsation here. And then what I'm gonna do is I'm gonna take my two rulers. I'm gonna take a ruler right at that pulsation at a 45-degree angle. I will have another ruler at a 90-degree angle right at the suprasternal notch. And where those 2 points intersect, that's the point where I'm going to measure, and that is 3 centimeters. I'm going to go ahead and listen to the carotids, make sure that there are no bruits present. I did that bilaterally, and no bruits were heard. And I am now going to palpate for any thrills or lifts on the aortic, the pulmonic, the tricuspid, and the mitral portion of the heart. I'm again feeling for any thrills or heaves. I'm looking at that precordium area and the point of maximal impulse. The point of maximal impulse on my patient is at the midclavicular line at the 5th intercostal space, and it is not displaced. I can also take this moment to just double check the arteries. So I'm going to be assessing the brachial, the radial, the femoral, the popliteal, dorsalis pedis, and the posterior tibialis. All arteries are at a grade 2. I'm going to look for jugular vein distension at this point in time, which I assess for when my patient turned their head. That is not present. I would also do that bilaterally. I think that's it.